1. Introduction and basic concepts. Definition. A single complete denture is a removable complete denture that occludes against one of the following opposing arches: natural teeth, partial or full dentition, fixed dental prostheses, FDP, an existing removable partial denture, RPD, an existing complete denture. Primary clinical consideration. Preservation of remaining tissue is the ultimate clinical goal. Natural teeth generate and transmit significantly higher occlusal forces to the edentulous foundation than artificial teeth do. Unfavorable force distribution causes accelerated bone resorption, mucosal trauma, and compromised denture stability. Adverse effects of uncontrolled forces. Severe ridge resorption and displaceable, flabby, or hypermobile, mucosal tissues. Extreme skeletal discrepancies, e.g., severe class 2 or class 3 jaw relationships, making proper tooth placement along the line of support difficult. Indications. A single complete denture is indicated when the opposing arch consists of a sufficient number of natural teeth not requiring an RPD or FDP. A partially edentulous arch restored, or to be restored, with an FDP. A partially edentulous arch restored, or to be restored, with an RPD. A satisfactory existing complete denture. Prevalence pattern. Longest retained teeth, mandibular canines, followed by mandibular incisors. Most common scenario, a maxillary single complete denture opposing natural mandibular anterior teeth. 2. Maxillary single complete denture. Diagnostic evaluation. Edentulous arch, evaluated identically to a conventional complete denture foundation, ridge form, mucosal thickness, tuberosities, undercuts, and posterior palatal seal zone. Dentulous arch, evaluated for tooth count, pulp, periodontal status, tilt, drift, supraeruption, and occlusal plane irregularities. Occlusal plane correction methods. Natural occlusal plane discrepancies, e.g., supraerupted or tipped teeth, must be corrected before final denture fabrication to establish a smooth, harmonious occlusal plane. Technique. Method and clinical protocol. Swenson's technique. Maxillary and mandibular diagnostic casts are mounted on an articulator at the correct VDO and centric relation, CR. Artificial teeth are set on the maxillary base, interferences on stone lower teeth are marked with pencil and reduced, and these marked areas serve as a direct template for intraoral enameloplasty. Eustace technique. Employs a U-shaped metallic occlusal template, convex on its lower surface, rested on the remaining natural teeth. Cusps causing interferences are identified, marked on the diagnostic cast, and subsequently ground intraorally. Bruce technique. Modifications are executed on mounted stone casts. A clear acrylic resin template is processed over the modified stone arch and tried intraorally. Natural teeth are selectively modified until the clear template seats completely and uniformly. Boucher's technique. Maxillary porcelain teeth are set on the edentulous cast to a corrected occlusal plane. The articulator is articulated so the porcelain teeth grind down opposing stone teeth. Marked ground areas on the cast direct the intraoral reduction. 3. Impressions, jaw relations and occlusal materials. Clinical protocols. Edentulous arch, custom tray border molding and secondary impression using standard complete denture principles, e.g., Zoe or elastomeric impression materials. Dentulous arch, alginate, irreversible hydrocolloid, impression following required occlusal plane modifications. Jaw relations, VDO, recorded via the Nisonga method or physiological rest position. Centric relation, static registration record at the correct VDO. Comparative analysis of occlusal materials. Material. Key advantages. Primary disadvantages. Clinical selection criteria. Porcelain. Excellent wear resistance. Preserves VDO long term. Severe wear of opposing natural enamel. Difficult to adjust, equilibrate. Contraindicated in restricted interclusal space. Best when opposing a porcelain restoration or complete denture. Acrylic resin. Zero wear to opposing enamel. Easy clinical equilibration. Rapid occlusal wear. Progressive loss of VDO. Indicated for short-term use of fragile edentulous foundations. Gold occlusals. Ideal wear dynamics against natural enamel. Excellent long-term stability. High lab cost. Technique-sensitive fabrication. Gold standard for opposing natural teeth. Acrylic plus amalgam stops, Winkler. Superior wear resistance to plain acrylic. Gentle on opposing teeth. Requires specialized lab, clinical modification steps. Cost-effective alternative to cast gold occlusals. IPN resin, interpenetrating polymer. High cross-linking gives durability. Preserves opposing natural enamel. Higher cost than standard acrylic resin. Modern primary material of choice for single dentures. 4. Occlusal schemes and dynamic balance. Achieving eccentric balance in a single complete denture minimizes destabilizing tipping forces. A. Functional chew-in techniques. Preferred when record bases are highly stable and the patient possesses good neuromuscular coordination. Stansbury's technique, 1928, carding wax is placed on a trimmed compound rim. The patient executes functional jaw movements to generate an occlusal path. Plaster, stone is poured onto this path to form a custom mounting template. Wiggs technique, 1964, uses an acrylic resin vertical fiend maintained at the correct video instead of a compound rim to guide functional wax registration. Sharry's technique utilizes a softened wax rim at an intentionally increased video, which the patient abrades down to the proper video through functional movements. Rudd's technique employs two maxillary record bases, one for recording functional paths using a blend of baseplate and counter wax, and one for final tooth arrangement. B. Articulator equilibration method. Indication: preferred when denture base stability is compromised or patient neuromuscular control is limited. Protocol: maxillary teeth are arranged on an adjustable articulator utilizing static CR and eccentric protrusive lateral registrations to set condylar guidance and achieve balanced occlusion. 5. Mandibular single complete denture. Etiology and rarity. Mandibular single complete dentures are clinically uncommon due to the typical sequence of tooth loss. Primary causes include extensive surgical resections or osteoradioncrosis secondary to radiation therapy. Severe maxillofacial trauma. Clinical challenges: high vertical and horizontal instability due to dynamic lingual border movements. Small denture-bearing area combined with high rates of residual ridge resorption. Thin, non-keratinized, highly displaceable mucosal coverage. Management hierarchy. Ideal strategy: implant-supported overdenture or fixed implant-supported prosthesis. Conventional strategy: maximize flange extensions within functional anatomical limits, utilize light occlusal contacts, and provide comprehensive patient counseling regarding anatomical limitations. Adjunctive support: application of resilient soft liners to cushion functional loads over severely resorbed ridges. 6. Combination syndrome, Kelly's syndrome. Definition: a characteristic destructive pattern of oral tissue changes resulting from an edentulous maxilla opposing natural mandibular anterior teeth and a distal extension removable partial denture. Diagnostic features: Kelly's original 5 classic features, 1972, resorption of the anterior maxillary edentulous ridge, replacement with flabby, mobile tissue. Hypertrophy, downgrowth of maxillary tuberosities. Papillary hyperplasia of the hard palate mucosa. Extrusion, supraeruption of mandibular anterior teeth. Loss of alveolar bone beneath the mandibular RPD bases. Saunders et al. Additional features, 1978. 7. Loss of vertical dimension of occlusion, VDO. 8. Occlusal plane discrepancy and derangement. 9. Anterior spatial repositioning, protrusion of the mandible. 10. Loss of denture adaptation and retention. 11. Development of epilis fissuratum in the maxillary labial vestibule. 12. Accelerated periodontal disease around remaining mandibular teeth. Preventive and therapeutic strategies: preserve posterior support, ensure maximum coverage over retromolar pads and stress-bearing regions, perform regular relining of mandibular RPD bases. Control occlusal contacts, maintain strict posterior occlusal contact in centric and eccentric positions, establish non-heavy or light contact on anterior teeth. Overdenture, implant therapy: retain strategic natural roots, root-supported overdentures, or place posterior dental implants to prevent anterior hyperfunction. 13. High-yield revision matrix. Domain. Essential concept. Primary goal: preserve residual structures by distributing occlusal forces safely across the arch. Most common scenario: maxillary single complete denture opposing lower natural anterior teeth. Occlusal plane correction. Correct natural tooth interferences before denture construction. Swenson, Yerkes, Bruce, Boucher. Optimal materials: gold occlusals, ideal, IPN resin, or acrylic resin with amalgam stops, Winkler technique. Functional chew-in. Dynamic occlusal path registration techniques, Stansbury, Wigg, Sharry, Rudd. Combination syndrome. Driven by loss of posterior lower support and anterior maxillary hyperfunction, triggers 11 classic tissue changes described by Kelly and Saunders.